اوكي الساعة 7:30 بتوقيت مصر. عندكم في المملكة 8:30. هنبتدي إن شاء الله كده slowly until other people start to join us. بسم الله الرحمن الرحيم. We're gonna be talking about invasive palliative interventions. I do believe this is a topic that's kind of under-taught in the palliative field for so many reasons. But I just want to say that the idea of palliation is an old one. I'm just quoting Hippocrates from Hippocrates from ancient time. To cure sometimes, to relieve often, and to comfort always. I'm sure all of you guys are aware about Cicely Saunders, but I just wanted to tell you about John Bonica. John Bonica is the founder of pain specialty. He started in mid-70s, and now it's an established specialty. He's from United States. He was actually in the army, and then after World War II, he kind of moved towards doing obstetric anesthesia. And then he started to do a lot of these pain blocks and injections, and his book is still the Bible in pain management up to now. So today we'll be discussing what is an intervention, an invasive intervention. And then we're gonna talk about just for a short period of time about neoplasm-related pain, indications, timing, and different approaches of palliative interventions. And then we can have some time at the end for questions and answers. I put this book because I do believe when I tried to look at the literature about palliative surgery and palliative interventions, the main focus was pain management, but really it extends beyond pain to cover all symptoms at end of life, including dyspnea, itching, and pain and nausea and vomiting and all that stuff. I found this book very useful, and I really encourage you to purchase it. It's written by a couple of Australian physicians, Matthews Wichman and Guy Medder. And I do believe that it's a good start. It could be better than this, but I think also that we can write a review article about different palliative surgeries and their role at end of life. The literature is very scant as far as I'm concerned. So this is also a prominent article that I found by Florian stressor, invasive palliative interventions, when are they worth it and when are they not? And I quote a couple of sentences here. First, he's trying to define what is an invasive intervention. And to be honest with you, this is really a difficult one, okay? And there's no consensus about it. But just kind of, this is what he came out with as far as the best, definition. He divided the definition into two parts. First, he defined what is invasive, and then he defined what is palliation. So an invasive intervention may be defined as any procedural injury of the body, the outer or inner skin. And as far as the palliation is to alleviate, to directly improve a patient suffering. And then he came out with this 7P model for decision making for palliative intervention. And basically, these are the priority, price, probability, prognosis, prevention, and preference. So, I mean, most of them are easily understandable, like the urgency of the procedure, the price, not just from a financial point of view, but also from a physical point of view. Maybe the patient doesn't want it because it will have a lot of burden on him, physically and psychologically. So this is part of the price. Probability. Will this procedure help the patient to improve his quality of life or not? And of course, the prognosis. Is this patient having less than 3 months, more than 3 months, and so forth? And prevention. Would this procedure prevent a complication? Like, for example, pinning a fractured femur. Would this help with ambulation, help preventing more complications later on? And then at the end is not the least, is the patient preference. Okay, every patient is different and he has his own priorities. Okay, we'll jump in. As far as the neoplasm-related pain, this classification is by Dr. Foley. Has nothing to do with the Foley catheter. But anyway, she classified this neoplasm-related pain to 6 sections here: acute, chronic, treatment-related, patients with a history of pre-existing pain, patient with a history of drug abuse, and dying patients. I always teach my fellows during the rounds, and I tell them that we have 6 different animals here. A pain is not the same, okay? But anyway, because this is not the topic of the lecture, I'll be just crawling quickly on it. We'll be talking about the treatment-related pain, like post-surgical, after a thoracotomy, after a nephrectomy, or a mastectomy is a very common thing. I've seen a lot at KFMC, post-mastectomy pain patients. As you see, when you do the mastectomy, you injure a lot of nerves, including the intercostal brachial, the lateral cutaneous nerve of the intercostals, and other nerves. So it's usually accompanied by quite a bit of neuropathic and nociceptive pain. Radical neck dissection, very common. I see a lot of these, and stump and phantom pain. Okay, so just bear in mind these syndromes because we see them a lot in our clinics. Radiation related, like osteoradio necrosis, lumbar and brachial plexopathies, myelopathy, radiation dermatitis, and neurogenic tumors. I've seen a lot of these osteonecrosis of the humeral and avascular necrosis of the femur head. I see them all the time in KFMC, in the pain clinic. and they have some relevance to what we're going to be talking about later on. That's why I brought these slides. Chemotherapy-related pain, such as oral mucositis, peripheral neuritis, acute and chronic herpetic pain, and osteonecrosis, like after administering bisphosphonates, for example. I had this picture, the upper picture, in the exam in my palliative boards, by the way, and they asked about the diagnosis. Procedure-related pain from lumbar puncture, even venipuncture, just a regular intravenous cannula can cause quite a bit of pain, and bone marrow aspiration. In children, I just want to mention that treatment-related pain is much more common than neoplasm-related pain. So bear this in mind, okay? Also, most of the tumors in the children are leukemias, lymphomas, sarcomas. So it's kind of different from the adult group. And usually these tumors are chemotherapy or radiation therapy sensitive. And even the presentation in children, usually fatigue more than pain. Fatigue is more common than pain in children. So we're gonna jump into the real bulk of the presentation here about the cancer pain management. I like to divide it into 8 categories. The upper 4 we're not gonna talk about, okay, during this lecture, for obvious reasons. And then we're gonna be talking about the lower 4, the pain intervention, surgical interventions, chemotherapy, and radiotherapy. So these are some of the pain interventions that we do in pain management for cancer patients and for palliative care. Of course, most of these procedures are done under fluoroscopy or ultrasound guided. It's in this day and age, we rarely do blind procedures, maybe just for like trigger points or something like that. But most of our procedures are fluoroscopically guided or under ultrasound. This is something that I always like to teach because it confuses even our pain fellows, unfortunately. What is somatic and what is visceral, okay? So nociceptive pain could be somatic and could be visceral, right? So sympathetic blocks are mainly for visceral pain because the visceral efferents run into the sympathetic nervous system, all right? Also, it could be helpful in other, sympathetically mediated pain, like complex regional pain syndrome, which is actually, we see this in cancer patients. Varicella zoster, okay? Herpes, peripheral vascular disease, and phantom pain. Of course, you can see a lot of this phantom pain in patients that had amputations for sarcomas or whatever. We'll be starting with trigger point injections, which is a very simple procedure that we do most of the time in our office. Trigger point injections are performed for myofascial pain disorders. And then I just want to show you some of these, like piriformis muscle syndrome in the upper left, and then you have, the psoas major muscle, the quadratus lumborum, and the gluteus medius. Okay, so these, I mean, if you look at it, all of them, they look like each other. Unless you have these pictures in front of you, you might really get confused which muscle is referring to this type of pain. But the good news are these are treatable, and actually they were found to constitute around 33% of cancer pain. So, I like to teach the fellows when they come some of these trigger point injections because they can do it in their office. It doesn't need a lot of expertise, but you have, we have to have some sort of an idea how to perform. And most of the time they're done with just very diluted lidocaine with or without steroids like dexamethasone. Okay, so this is the simple part. We're gonna jump into the more difficult, which is neurolysis. So we do a lot of neurolysis, and neurolysis can be done chemically or through physical agents like radiofrequency or cryoablation. And this is just a comparison of the most famous ones in pain management, the phenol and the ethyl alcohol. This is not the alcohol that you find in your wards, by the way. The one that you have in your wards is isopropyl alcohol. This is called ethyl alcohol, okay? And it's available in KFMC. The phenol is not available, but the ethyl alcohol is available. It's a hypobaric agent. In other words, if you inject it in the CSF, it will float upwards. And it's irritant. The phenol is not irritant. The phenol will anesthetize the area directly, okay? And the mechanism of action is different. Then you have radiofrequency, which is basically burning the nerve. Now you have a conventional type, which is neurodestructive, and you have a pulsed radiofrequency, which is not neurodestructive. You do the radiofrequency in a pulsed mode. Now, why do we do? Why sometimes we need to destroy, and why not? So in pulse mode, we use it in procedure that we do not want a motor injury, motor weakness, like a nerve that could cause weakness in this area of the body, okay? Or, paralyzing the nerve could be a problem. For example, brachial plexus, for example. Let us say I want to do pulse to a radio frequency for brachial plexus. I cannot really do the convention because I will paralyze the whole upper extremity. So I use the pulse in this situation, okay? Of course, the conventional gives you better results because you really burn the whole thing. But it also has its consequences. It can cause neuroma formation, and it can cause more pain after the procedure. We can also do what we call cryoneurolysis, or freeze the nerve. And this is done by special machines and a phenomena called the Joule-Thomson effect. In other words, when you decompress a gas like CO2 or nitrous oxide at the end of this tube, you develop this ice ball. Cryoneurolysis is a good way to do things because it's similar to pulse radio frequency. It does not damage the nerve, okay? It only causes what we call in the Sunderland classification, first degree or second degree injury, neuropraxia or xanthemesis. And this actually is not neurodestructive. Cryoanaesthesia, in old days, we used to use very large probes. I remember in 2000, 2010, I used to borrow the machine from the ophthalmology folks, and it was a very large probe, like 14 gauge. Nowadays, they have the smaller gauge needles, and it's coming again after years of most interventions neglected the cryoanaesthesia. Now they're coming back because they were able to develop smaller needles similar to the size of the radio frequency needles. Subarachnoid neurolysis. This is done chemically either with phenol or with alcohol. And this is a very common board question for the pain management folks. This procedure, by the way, doesn't need a C-arm or doesn't need any, just the medication, the phenol or the alcohol, and how to position the patient is very important. So because phenol is hyperbaric, we turn the patient to the semi-supine. This is the picture on the left, okay? Because it goes down by gravity. And for alcohol, the patient is positioned semi-prone. And this is an extremely common question in the pain board. Now, do we still do this procedure? Yes, in some areas of the world, mostly, underdeveloped countries, because it's extremely cheap. Uh, in the United States and Europe, they're, getting away from it by doing intrathecal pumps. But of course, some old physicians still use it every once in a while. So it needs to be known at least. And the main indications are chest wall and perineal pain. Chest wall pain, cancer related, and perineal pain. Okay, we're gonna go through these by region right now. Head and neck. I always tell our fellows, head and neck pain is simple. The treatment is pharmacologic. Try not to do a lot of procedures in the head and neck, because most of these patients that get sent to us, they have anatomic distortion. And if you try to mess around with the needle, even under fluoroscopy, you can get into a big disaster. So try to avoid it as much as they can. But every once in a while, you will need to do a procedure. Like, for example, patient had shingles. So you need to do like a stellate ganglion block to treat that. So one of the common things that we see in the palliative setting is the CP angle tumor. And this, can give you different manifestations in as far as facial pain, trigeminal pain. But we don't really do a lot of these Genserian ganglion block, which is the ganglion of the trigeminal nerve, which sits just above the foramen ovale. We do this procedure mainly for non-cancer indications like trigeminal neuralgia, for example, but not for cancer. Okay, I just wanted to clarify this part. All right. Actually, maybe we can do the branches because it's safer. These are peripheral branches of the trigeminal, and it's easier to block and would not cause a lot of complications. The stellate ganglion, we use it for sympathetic mediated pain, mainly shingles, okay, and complex regional pain syndrome. And usually we block this ganglion at the C6-7 area, as you can see here. And it's usually causes what we call Horner syndrome, okay? So this is just part of one of the things that causes a Horner syndrome. Okay, how about upper extremity pain? This is more common than other types of pain because the prevalence of breast cancer, all right? The other problem is you cannot ablate the brachial plexus because if you do so, you cause a functionless limb. So usually we try just local anesthetic, steroids. You can try pulsed radio frequency. You can, if it's a shoulder type of pain, we do what we call suprascapular nerve block. And at last, something called percutaneous cardotomy, we're going to talk about later on, which is gaining some momentum in Europe nowadays. So this is the suprascapular neurolysis. We did tons of these at KFMC. You can actually ablate this nerve with phenol. It can cause some weakness and abduction, but it's not a major issue. It's not like you're putting phenol in a brachial plexus, for example. And it's a very simple and straightforward procedure. Thoracic sympathetic blocks, mainly for lung cancer, or again, visceral pain, or complex regional pain syndrome in the upper extremity. Unfortunately, the thoracic needs a little bit of expertise because there's a higher incidence of pneumothorax, up to 6%. As far as thoracoabdominal pain, again, we need to classify the pain, whether it's somatic or visceral. So if it's somatic, you do the intercostal blocks, okay? If it's visceral, you do the thoracic sympathetic block. And if it's upper abdominal visceral, like the liver or large intestine or pancreas, we do something called celiac plexus block. So this is the intercostal block. It's done underneath the ribs. The neurovascular bundle runs underneath the ribs. By the way, it's a safe procedure, and the risk of pneumothorax is rare. Okay, despite it's almost like next to the, because you have to injure really the visceral pleura, not the parietal pleura, to get the pneumothorax, because the air has to come from inside, not from outside. So it's kind of rare if you know how to do it to cause pneumothorax. Celiac plexus block is one of the very famous and prestigious blocks in cancer pain. And it's basically done for upper abdominal malignancy, like liver, pancreas, large intestine, until the colonic flexure with the descending colon. You can do a celiac plexus. And there are a lot of doctors, doing the celiac, like pain physicians, of course, intervention radiologists and gastroenterologists. So there's an overlap between different physicians. Each of us use a different technique, but the bottom line is to neuralize this plexus that runs around the celiac artery. Okay. Now, if you inject before the celiac, inject these nerves here, this is called splanchnic nerve block. Splanchnic nerve block and celiac plexus block are the same procedure, except one you do it before the cross of the diaphragm, and the other one beyond the cross of the diaphragm. So it's just a technical thing. But if you hear the word splanchnic versus celiac, for you as a palliative physician, it means the same thing. This one is done by gastroenterology people, where they're putting a scope and ultrasound guided. They can block it from inside the stomach. And even surgeons, while they're doing the surgery, let us say they're doing a Whipple surgery, they can also inject the celiac plexus under vision with alcohol. The results are magnificent, 80% relief, and it can stay up to 12 months. What are the main complications? First of all, you have to explain to the patient, okay? There are two major complications and two minor complications. The two major complications are paraplegia and actually dissection of the aorta, okay? They're pretty rare, but they can happen. And the main minor complications, hypotension, because it causes splanchnic vasodilatation, and diarrhea, okay? And these are transient, but I had a case, for example, I did this on him. This patient went home, had diarrhea, and didn't get enough fluid, came back to the ER with hypotension. I mean, we just gave him some fluids and he did well, but I just wanted to explain to you. The other important thing, guys, when you have a patient that have a celiac plexus, let us say in the palliative team, the patient's coming back from the interventional suite, whatever, after the block. Please cut down his medication by 50%, because if he gets good relief, you don't need this amount of narcotics that the patient is taking, okay? And also you cannot stop the narcotics cold turkey, because you actually can cause withdrawal symptoms and diarrhea, as you know. So you complicate the situation. So if you have the block, if one of your patients have the block, please reduce the amount of opioids by 50%. For pelvic pain, we do either the intrathecal pumps, or we do for visceral pain something called superior hypogastric block, or sometimes we do the subarachnoid neurolytic block for somatic pain. So this is the hypogastric plexus. Hypogastric plexus is a plexus that's in front of the L5-S1 junction. And this supplies all the viscera, like the bladder, the uterus, the rectum, okay? All of these are pelvic organs, prostate, and it's a relatively new procedure. Just came out in the early 90s from a guy from Mexico, the head of the pain department in Mexico. Lower extremity pain, again, we can classify them somatic, visceral, sympathetic mediated, like we do lumbar sympathetic blocks for that. Sacral root block for somatic pain. And sometimes we even do percutaneous cordotomies. This is the sacral nerve root neurolysis. Of course, you have to know the anatomic background to these blocks and the distribution of each nerve. So you block the right nerve. And all of these are done on the fluoroscopy. This is actually considered a simple shot. A lumbar sympathetic block is present in front of the L2, 3, and 4. This is the lumbar sympathetic block. If you do neurolysis, there's a very famous complication, usually asked in the exams. And this is why I brought it. Really, I don't really like to talk about lumbar sympathetic neurolysis, but it's a common thing. Because of its location, it can actually cause something called genitofemoral neuralgia. The alcohol can go, or the phenol can spread to the genitofemoral nerve and gives you this severe groin pain. Could be worse than the original pain in this area, okay? So this is a very common question. Perineal pain, you deal with this with subarachnoid neurolytic block, or pudendal, a block, or ganglion of impar. Ganglion of impar for the visceral type of pain of the perineum. Start with the pudendal. The pudendal supplies the somatic aspect of the perineum, including the penis, the scrotum. I had one time a patient with colorectal cancer and penile metastasis. And this was one of the most painful things I've seen in my life. And I had to do this pudendal neurolysis for him. So I wanted to explain it to you. It's a very simple procedure. You inject the nerve basically at the ischial spine here, at this area. You do it with C-arm. The patient is on the prone position, and you just go there. The ganglion of impar is the last part of the sympathetic chain, and it's located usually between the sacrococcygeal junction here, okay? And you approach it from behind. And it's useful for visceral perineal pain, like anal pain, for example. vulvar pain. Okay, this kind of pain um, will need a ganglion impart. Okay, now we'll jump into some of the neurosurgical interventions, okay, such as doing a tumor resection or intrathecal pumps or some of the ablative procedures. Now, I want to say, guys, I always try to explain to the fellows what is there, okay, updates, because there are a lot of procedures that we don't do anymore, okay. So one of the uh, procedures that gaining momentum is the intrathecal pumps for cancer pain, okay. Most pain physicians are getting away from intrathecal pumps in non-cancer patients. Okay, so mainly the main two indications nowadays for the pumps are either cancer pain or spasticity. And I know that, for example, in KFMC, there are a lot of baclofen pumps for spasticity, okay, for patients that had a spinal cord injury, all right? So it's the same type of pump, but we inject different materials. All right. The interspinal systems, you know, they can be just a simple DuPen, like an epidural catheter, or like a portacath, or a programmable pump. All right. And this is a portacath. It's very similar to the one they use for infusions, IV infusions. The DuPen is like a regular epidural catheter that's more sturdy, and it has like a connection that comes out of your skin here and it gets tunneled in the skin. We do this portacath or the DuPen in patients that have lifespan less than 3 months, because really the real pumps, the programmable pumps like the Medtronic and others, these are pretty expensive. And these are, you know, basically tunneled underneath the skin, go into the intrathecal area. The catheter goes all the way up to T11, okay? And the pump is usually, you know, placed in the abdomen, okay, in the subcutaneous area of the abdomen, where you can fill it up here in the middle, okay? So this is the access port here to the medication that you're gonna inject. All right, now, what is the importance of these pumps, okay? And I can explain it to you in this one slide here. If you're giving morphine orally, okay, 300 milligram oral morphine, this will be equivalent to about 100 milligram IV, equivalent to 10 milligram in the epidural space and 1 milligram in the intrathecal space. So this translates to less side effects and more effectiveness, because you put the medication where the receptors are, okay, which are basically in the substantia gelatinosa volandi in the dorsal horn of the spinal cord. So you inject it inside the thecal sac. So that's why you don't need as much. As any intervention, it has its complications. These complications could be related to a pump itself, okay? For example, in this picture, this pump is flipped, okay, underneath the skin, so you cannot access it, all right? So the patient can get withdrawals, right? Or it could be related to the pocket, and I've seen a lot of these. After the surgery, they get something called seroma, all right? And usually it goes away by using like abdominal binders and stuff like that. And it could be related to the catheter. So it could be granuloma, disconnection, fibrosis. I wanted to show you this picture here because this is very important. This is a granuloma, okay? And again, I told you the tip of the catheter is usually placed around T10, 11 area. So if you develop this granuloma, it can push on the spinal cord, okay, and can cause quadriparesis, and it can cause ataxia, and can also cause patient not receiving the medication adequately. Now, fortunately, we found the real cause of this granuloma. This is a sterile granuloma. It's not infection. And the real cause is basically high concentrations of the opioid, especially morphine, all right? And next to it is hydromorphone. And that's why they put some regulations as far as the concentrations of these drugs. Fentanyl does not cause this granuloma, which is an advantage. But anyway, you can easily detect it. I usually just tap on the knee joint, and you get hyper exaggerated knee reflex, and this will tell you immediately that there's a pressure on the spinal cord. This picture from Medtronic company, and it shows you the commonest complications of that you will encounter with pumps in general. So as you can see, the commonest thing, this could be exam question, is dislodgement or migration of the catheter. Okay. Also, I wanted to show you this Polyanagestic Consensus Conference. This is a conference that's conducted every few years and will give you the guidelines for the medication that you should use in the pumps. So I want to stress on this because this is important. For cancer patients, the first drug of choice is morphine, okay? Now for non-cancer patients, it's something, a new drug called ziconotide. Ziconotide is basically the gabapentin that you can inject intrathecally, similar to gabapentin, because it works in this N-type calcium channels, all right? Extremely effective, but it can cause a lot of CNS side effects. And thus you have to titrate it very slowly. And if you do so, it works beautiful. And it's extremely expensive. It's under the name of Pre-Alt, all right? So this is number one choice for non-cancer patients. But for cancer patients, it's morphine, all right? And this is the Conus magus, is the snail that they extract this ziconotide from. And it's abundant in the Red Sea, by the way. And this is the way it hunts its prey, by injecting this material. So it kind of paralyzes, sort of like a euthanasia to their prey, sort of. I'll jump into the another procedure called the percutaneous chordotomy. This percutaneous chordotomy, it's an old procedure that came back to real life recently, especially in UK. Okay, and the main indication, remember this for the exam, all right, is mesothelioma. Okay, it's used mainly for severe costal pain related to mesothelioma. Okay, it's the way you do it, you go between the C1 and C2 in the contralateral area. Okay, so and then you do the radio frequency for the anterolateral spinothalamic tract. Now the problem is you have two structures here. They're pretty serious. This is the pyramidal tract, and this is the reticular formation. So the pyramidal tract will cause, of course, weakness, right? And the reticular formation can affect the breathing centers. And thus, you cannot do this procedure bilateral, because if you attack the reticular formation on both sides, you will develop something called central apnea. This is not obstructive apnea. This is central apnea, okay? Sometimes they call it Ondine curse. And this has a story behind it, but I don't have time to talk to you about it. But central apnea patients, unfortunately, they have, whenever they go to sleep, they stop breathing. So they have to have the ventilation, otherwise they will die. Another procedure is called dorsal myelotomy. I want to say these procedures, by the way, it's not commonly done in neurosurgery. There are few neurosurgeons that do this procedure. These are what we call them functional neurosurgeons. So you might be lucky in your hospital that you have a functional neurosurgeon. If you have it, have him ask him whether he can do these procedures or not. Okay. Dorsal myelotomy. This is kind of another beautiful procedure where they do myelotomy to the dorsal tracts, the gracile and cuneate. I mean, if you remember from old days, gracile and cuneate tracts were the main tracts for proprioception, right? But recently, I would say maybe 15, 20 years ago, they found they transmit visceral impulses. Okay. So do this dorsal myelotomy. Another procedure is called the DRES. Again, this is an old procedure. There's nowadays they're getting more momentum, and this is mainly for something called deafferentation pain. Deafferentation pain is where the nerve is. Sometimes they call it anesthesia dolorosa, where the nerve is completely anesthetized, but it's very painful. Okay, and it happens with plexopathies. All right, like brachial plexopathy or lumbar plexopathy. Pancreas tumor can cause deafferentation by injuring the brachial plexus. Okay, also herpes. Okay, post-herpetic pain. All right, can cause deafferentation pain. All right, so this is a new surgical procedure. This is not something pain physician do usually, and mostly again functional neurosurgeons. Percutaneous vertebroplasties. This is done at KFMC, and basically injecting cement in patients with metastasis that cause fractures in the body or aggressive hemangiomas. When you inject the cement in the body, actually, you first of all stabilize the vertebral body so it doesn't hurt. Anything that's fused will not hurt. Okay. Number two, it exerts a lot of temperature when it gets injected, and this temperature attacks this small nociceptive fibers inside the vertebral body, and it helps with the pain. There's another procedure that's similar to vertebroplasty called kyphoplasty, okay, where you put a balloon and inflate the body before you inject the cement, creating some sort of a void before you put the cement in it. And the main advantage of this procedure, on top of the vertebroplasty, that it can restore the height. I'm sure you've seen a lot of people with severe osteoporosis, with kyphosis, severe kyphosis, from the fracture. So this will help, and this has an impact, of course, on the pulmonary function test. Be better. GRC is the gray ramus communicans. It's a nerve running on the side of the vertebral body, and usually we use it for failed, vertebroplasties, or a patient that is not, is a contract prolapse on the spinal cord. You cannot, do that. All right. Now I'm going to talk about palliative surgery. All right. And this famous doctor, Theodore Belroth, said that, sometimes we do this gastrectomies. This is a very old quote, for palliation more than we do it for curing the patient. So these are some of the surgical procedures that we use nowadays for palliation, like draining an ascites, pleural effusion, or pericardial effusion, laparotomy or laparoscopy, and bypass for resection and relief for biliary or bowel obstruction, debulking or resection of the tumor, doing a PEC tube gastrostomy, placement for relief for the obstruction, craniotomy. Sometimes we do craniotomies just for the sake of palliation, fixation of a pathological fracture, amputations, tumor embolization procedures like for hepatocellular carcinoma, the chemo, what we call chemoembolization, cystostomy for bladder outlet obstruction. Sometimes we do even simple mastectomies, to relieve some of these symptoms. Tracheostomy for dyspnea, and vascular access. I want to say that these procedures, nobody really, except this book that I found that I showed you at the beginning of the presentation, nobody really wrapped it in a nice way. And I think it could be a good review article for those of you that are interested to write an article. So I'm just gonna talk about some of them, of course, not all of them. Like, for example, fracture lung bones. We see this a lot in the palliative world. We use something called Merrill criteria to decide whether this patient would need a prophylactic fixation or not. If the score is more than 8, you require a surgical stabilization. Okay, and you can see it comes into 1, 2, and 3. Of course, if it's in your lower limb, we will have a higher score because you need it for ambulation. Also, the type of the lesion. If it's lytic, this is worse than blastic because the lytic can lead more to fractures, and thus, patient will not be able to ambulate. Okay. By the way, even if the patient has less than 3 months, you still can do this procedure because just enough it will help the patient to ambulate the rest of his life. I think this is worth it. So this is the procedure done by ortho, which is pinning of the femur. Other procedure like a Foley catheter, although it's a simple procedure, but I want to tell you that urine retention is so common in the palliative world because of opioids and because of constipation. Sometimes you do suprapubic cystostomy. Like I had a patient here in Egypt, I see nowadays, that had sarcoma in his perineum related to the human papilloma virus, very rare cancer. So they had to do the cystostomy because he cannot, urinate to, to his penis and all that. So that's why they did a suprapubic cystostomy. So just kind of remember this. Now we're going to talk about IV access. By default, guys, we do a peripheral IV. Okay, this is the most important one. All right, but in the United States, I remember, I don't know whether we have it here or not, something called midline. Midline is basically a long IV. Okay, and it's done under ultrasound guided. Usually the nurse does it. Nurse does the PICC line. It does the midline. The nice thing about the midline, it's very stable. It doesn't come out, okay? And also it doesn't go to the central area of the body. So this is not like a PEC line where it goes centrally, all right? Um, I'm not sure we have it in our areas or not, but something to really think about. Uh, and another axis is the subcutaneous. This is a very famous axis to palliative physicians, and they have to educate themselves about it, okay? Because a lot of times you don't have any access and you don't want to put a central line, and thus, you would use the subcutaneous axis. So you need to educate yourself about it. This, you can give up from 1 to 2 liters per day in this subcutaneous area, and you can inject through it. And so kind of bear this in your mind. Um, of course, we get scared about infection, so it needs to be changed every 72 hours. Uh, but if it's not infected, you can keep it. Also, if the patient is thrombocytopenic, you should not do a subcutaneous, infiltration, because this will end with a hematoma. Other lines that you should be familiar with, but like the Hickman, the PICC line, and the ports like the portacath. Now, if the patient comes to me already with these catheters, I don't remove them. I keep them because they're helpful. I can use them for my stuff, okay? Instead of, keep poking the patient, all right? Unless requested or the patient is moving from the hospital to a very remote area that I don't think there will be anybody that will care about this, catheter, then I would take it out. Pericardiocentesis is another important procedure for malignant pericardial effusions. Sometimes we do what we call pericardial sclerosis, where we inject bleomycin or tetracycline if it becomes recurrent. And if the patient has more than 1 month, estimation of lifespan, we sometimes we send them to our surgical colleagues in cardiothoracic. They do what we call a pericardial window. As an anesthesiologist, I've done, I put to sleep a lot of these folks, in old days. Thoracocentesis, the same principle for pleural effusion. You can use this pigtail. You can also do pleurodesis for recurrent effusions with bleomycin or tetracycline. You can use bronchial stenting or tracheostomy for upper airway obstruction or for example, bronchial tumors. Sometimes they do laser ablation for these tumors, fungating tumors in the bronchi. All of these are considered palliative procedures. These are not for cure, they don't have a curative intent, but they relieve a lot of these symptoms from the patient. A nasogastric tube, sometimes useful if you have obstructed bowels, but of course, you should not use it for long term. You should use it only for short term. Esophageal stenting, if you have a tumor in the esophagus that's causing dysphagia, or stenting of the gastric outlet or the colon. So we have multiple procedures that can help with the symptoms, okay? Without doing, all of these are done endoscopically. So our GI colleagues can help you out with making these decisions. Or a PEG tube, okay, for nutrition. So if you have a patient with head and neck cancer, what are you gonna do? You have to feed him, right? Especially if he's gonna get surgery, radical neck dissection, he's gonna do this, that, all right? But this is not done for like dementia patients. This, like in old days, like every dementia patient would get a PEG tube. We don't do this anymore. But we do it in specific indications like head and neck cancer, patients with amyotrophic lateral sclerosis, for example, HIV, and stuff like that. There's also similar procedures called the venting gastrostomy. Sometimes we do this for obstructed bowels. Biliary stents are used for obstructive jaundice, okay, causing a lot of symptoms like itching, for example. Um, this is done endoscopically. As far as patients with acute renal failure, we can do percutaneous nephrostomies, or sometimes if you have a tumor obstructing the ureter, we do what we call double J ureteric stents. So anyway, I just gave you a quick review. Of course, this book that I showed you, Palliative Surgery, has more details about these procedures. Please look it up, because really as a palliative physician, you should be able to send the patient appropriately to the right person. If you think this patient might benefit from a stent, for example, or esophageal stent, or a patient might benefit from a nephrostomy or whatever. So unless you understand the principles behind it, you'll not be able to send the patient to anyone. So I would really encourage you to look into these procedures. We have something called palliative chemotherapy, and anyone that worked with oncologists, they know what does it mean. It's basically to reduce the tumor load, so it reduces the symptoms, but it's not curative in intention. And usually we try to minimize the amounts so it doesn't cause toxicity. Um, and um, and it's sometimes we need it as a part of a multimodal treatment to reduce for palliation. So sometimes patient comes to us and we still give him this palliative treatments. It's okay. Also, we do also what we call palliative radiation by the radiotherapy department, okay? And this could be useful for different types of conditions, like bone pain, spinal cord compression, fungation, skin tumors, relief of obstructions like superior vena cava, airway obstruction, esophageal obstruction, brain metastasis, okay, and sometimes to reduce the tumor bulk. By this, I would end my lecture, and I'll be more than happy to take any questions. Dr. Abdulhalim, any questions? يا شباب حد سمعني؟ حد سامع ولا مع؟
أيوة دكتور أيمن سامعينك، كاتبين على
أوكي.
الشات أسئلة.
اوكي، كاتبين فين؟ على الشات؟
أيوة.
اوكي. معلش، it's okay. And suppose it was not successful. Okay. Sorry, معلش, I didn't see this. السلام عليكم يا جماعة إن شاء الله. Thanks again. Why we didn't see this procedure done in our hospital compared to this? I'm not sure which procedure, Dr. Abdullah Suhail. Which procedure?
السلام عليكم. معليش
السلام.
انا حاولت اتكلم معلق لكن كان الهوست مسكر علينا.
لا
الله
ولا
يعطيك العافيه
يهمك.
دكتور. فيري نايس الحقيقه برزنتيشن، اي انجوي يعني كل المحاضره. لكن انا لاحظت لما كنت في تريننج اوتسايد كان عندنا الانترفنشن دائما موجود، حتى كانت في عياده كومبايند بين الباليتيف والانترفنشن، وكان كثير من البروسيجر هذه اللي تكلمت عنها زي السيليك بلاكسس، النيرف بلوكس، كثير منها الابيديورال، كلها يعني نشوفها بشكل اسبوعي. انا الحقيقه لي 10 سنين من جيت، ويعني تقريبا ما الحالات اللي اكسبتد يعني نسوي ريفيرال اغلبها ريجكتد. يمكن لما كنت موجود عند الدكتور كنت تحسن الوضع شويه، بس الآن وقبل يعني كل ما نحول حالة يجينا إنه not fit for procedure. أنا ما أعرف عندنا نقص في مثلا التكنيكال سبورت، هل مثلا في مشكلة يعني معينة، ما الستاف عندنا ما هم تريند ويل بحيث إنه افويد. حتى إن أتذكر إنه أحد الزملاء يعني من البين سبيشالست قال ما كان بيشنت على هاي دوز اوف اوبيويد، قال أنا ما أقدر touch the patient until you hold everything. احنا قلنا له نقدر ننزلها 50%، اللي اعرفه انا انه كت 50% اوف اوبيويد. هو قال لا you have to stop everything وبعدين احنا نبدا نتدخل. فما اعرف يعني هل في مشكله انت يعني من خبرتك
والله يا دكتور اتفضل. بص يا دكتور عبد الله،
هل في مشكله يعني من التريننج ولا في مشكله في اكويبمنت
لا
موجوده ولا ايه؟
بص هو الموضوع يعني طبعا it has to be done stepwise fashion. لان انا طبعا لما جيت انا قعدت 3 سنين وكده، ففي حاجات اهم من حاجات. يعني بالنسبه لنا مثلا كبالياتيف we need to start قبل ما نبتدي بالانترفنشنز لازم نبتدي مثلا بحاجه زي البي سي اي، واخد بالك، وبعدين نعمل ابيدورال سيرفيس. دلوقتي انا هعمل ابيدورال سيرفيس لازم يبقى عندي تيم كامل يعني to follow up on these patients. زي البين team we should have another team for it needs physicians need to be trained, you need nurses to be trained. يعني أنا مش بقول إن هي مش مستحيل ولا حاجة، أنا بقول إن هي لازم نعمل يعني ناخد المواضيع دي إيه one goal at a time. شوف إيه الأهم، يعني نعمل prioritization. فأنا ده وجهة نظري إن الأول نبتدي بالأسهل واللي اللي في إيدينا اللي هو زي البي سي ايز، وبعد كده نبتدي ندخل على مثلا موضوع الابيدورالز وهكذا. طبعا احنا عندنا deficiency في البيرسونال التريند، لان يعني مثلا معظم الدكاتره البين for example they're working 2 jobs, they're doing anesthesia and they're doing pain. maybe I was the only one doing pain and palliative, but the rest of them يعني they have other duties as well. So يعني أنا هقول لك على حاجة يا دكتور عبد الله, you will not يعني believe me. انا رحت MD اندرسون، كنت بعمل يعني اسمه ايه ده كورس هناك. واللي حصل ان لما رحت الكورس دوت لقيت الاكيوت بين سيرفيس عندهم فيهم 17 فيزيشن. ده الاكيوت بس، اكيوت بين، واخد بال حضرتك؟ فلا طبعا احنا we need more personnel, we need and as I said, we need to go step by step in our يعني goals. نبتدي بالبي سي اي، بعدين ندخل على ده، ندخل على وهكذا. Any other questions?
مساء الخير دكتور أيمن.
اتفضل.
يا حبيبي، في اسئله في الشات انا بقرا لك. في سؤال من دكتور
انا شايف سؤال shall we يعني بالنسبه لل reducing, anytime you do a procedure that's successful, you should reduce the dose of the opioids. This is like ABC, and I think 50% is a good number, because you don't want to overdose and you don't want to get withdrawals in the same time. Are these blocks done with the use of chemicals like alcohol or done? بنستخدم احنا زي ما قلت لكم بالنسبه للنيوروليتكس chemicals زي الالكول and phenol. We have also the radio frequency machines, and this is available in KFMC. But we also have something called cryoanalgesia, which is basically something that's coming, يعني very promising way of doing things, you know, because it doesn't cause neural destruction. Any other questions? I think I answered all the chat questions. يعني أنا really I want to encourage the fellows to really think about writing an article about you know, the role of palliative surgeries in palliative care. I mean, you don't have to be a surgeon to write this article, okay? But you just need to get the right information. I think a lot of most of the literature is focusing on the pain procedures, but there are a lot of these palliative procedures that I do believe that palliative physicians should be aware of. Okay, for example, IV access. Okay, how many of us know different IV access? Okay, thoracocentesis, pericardiocentesis, you know, stenting. I mean, we need to wrap this up in a nice review article. I think will be a very useful one. Any other questions, guys? Okay. All right, I think we're done then. I know that I'm trying to see if there's anybody. wrote in the chat here. Okay. اوكي شكرا جزيلا وان شاء الله نشوفكم الشهر الجاي. I'm gonna be starting some of these presentations about يعني palliative care in non-cancer patients. So we'll be starting next month, inshallah. We'll be talking about neurological diseases, such as dementia, multiple sclerosis, Parkinson's disease, and so forth. And then every month will be, a new one, cardiac, then COPD, and so forth. All right.
إن شاء الله يعطيك العافية دكتور أيمن.
الله
إلى
يخليك.
اللقاء.
شكرا جزيلا.